Hello, everybody. I am Dr. Valerie Libby. I recently completed my fellowship training in reproductive endocrinology and infertility, and am joining Shady Grove Fertility in Atlanta this September. I am excited to introduce to you our next speaker, Dr. Brian Levine. Dr. Brian Levine is the founding partner and practice director of CCRM New York. He is board certified in both reproductive endocrinology and infertility, as well as obstetrics and gynecology. Dr. Levine attended medical school at NYU, completed his OBGYN residency at Columbia, and then completed his fellowship in reproductive endocrinology and infertility at Cornell. Dr. Levine has over 50 publications and has received multiple honors and teaching awards. He is speaking to us today about conquering diminishing ovarian reserve. Please welcome Dr. Levine.
Thank you, Dr. Libby. I appreciate you saying that very generous introduction. Please feel free just to call me Brian, because I feel like we need to really get to the point with our doctors where everyone understands that we're partnering with everyone's care. Thank you to PUAH as well for inviting me to this really outstanding conference. It's both a pleasure and honor to be presenting to you today. Today we're going to be talking about one of my favorite topics, because I think this is the one that makes me take the biggest pause. Helping the most difficult patients that are out there. And so those difficult patients typically fall into the subheading of diminished ovarian reserve or low egg count. Now, before I get started, I want to say that it's truly a pleasure and an honor to be amongst all these amazing speakers who've been participating between yesterday and today. And I have to say that I would feel more than comfortable knowing that any of my friends or family members are being treated by any of these doctors. So it's really an honor to be in such an esteemed group. And thank you as well to our sponsors as well. Just in case you're wondering who CCRM is, we're a network of clinics. So we have 11 clinics in North America, and we're located where almost every speaker is coming to you from today. So if you have any questions at the end of this, or if you feel like you want to know where we can learn more information about something, there's probably CCRM near where you are right now, and we're happy to talk to you. This is your New York team, and I'm coming to you live from Midtown Manhattan. Right outside our front doors, the Hope sign, and it's quite fitting that it's there, because that's really what this is all about. You know, when you come into the office, and if you have the diagnosis of diminished ovarian reserve, sometimes it feels like hope is the only thing that you have. Well, in reality, we have lots of ways to approach it. I will say that we're going to request audience participation. One of the true fundamentals of being a doctor is being a teacher. And I feel like quite often, when we start going through really difficult topics such as these, many patients during seminars tend to have this just glazed over look, because sometimes they just don't understand a concept, or sometimes the presenter doesn't do a very good job explaining it. So please feel free to give us comments. You can type that in the bottom right corner, and then we will see them as well. But please give us comments and feedback, and I really look forward to answering your questions. So infertility is incredibly common. As we heard yesterday, it's the third most common medical issue that providers deal with. In fact, 12% of women or partners will need fertility treatment at some point in their lives. 1 in 8 couples will deal with infertility. But when we look at the breakdown of infertility, there's 3 groups that we think about. Those who have the female factors, as you heard about yesterday, and the male factors, as you heard during the afternoon. Sometimes it's the combined together or the unexplained. But if you take a look at that female subset on the left side, in that subset, it feels like it's very heavily weighted by those with diminished ovarian reserve or low egg count. We all know that as someone gets older, there's a direct impact of age on egg quantity. In fact, on a month-by-month basis, women who are 20 to 30 years old have approximately an 18% chance of getting pregnant. As women get older, and by the age of 35, they have approximately a 10% chance of pregnancy. On the right-hand side, you'll see in the pink bar that egg reserve or quantity goes down, and that's directly related to the monthly birth rate on an age basis. As we're dealing with a decreasing egg quantity with age, we tend to also be combating an increased incidence of problems. So if you think about it, these two curves are crossing over each other. So the light pink is the chance of having an abnormality or a miscarriage or a complicated pregnancy. And the dark pink is the chance of having a normal pregnancy. And so what you can see is that as someone gets older, their chance of having a problem goes up and their chance of having normal eggs goes down. Now, as people talk about the treatment of infertility and the assessment of patients with infertility, and specifically diminished ovarian reserve, they start to learn from their friends and family members and from amazing conferences such as these, and from resources such as PUAH's amazing resources and rabbinical oversight, that infertility is really common. Right? I hope if you take one thing away from this talk today, is to know that you're not alone, and that infertility affects more than you would ever recognize. Right? We started this talk by saying 1 in 8. But in fact, if you look at the United States as a nation, it was in 2016 that for the first time for more than 3 decades, that women 30 to 34 had more babies than 25 to 29. And this is because people tend to be waiting a little bit longer. And we know that people are waiting longer, so they're having more issues. But more importantly is, some people are still not getting treated for infertility. When someone comes into the office, I always say to them, let's figure out why you're here, right? It's important to ask the patient, what can I do to help you? But when you break it down, you have to figure out why they're in the office. Why have they landed into the infertility doctor's office, and what can we do to help them? Here at CCRM, we call that the one-day workup. That's kind of our catchphrase, because even outside of COVID, we've consolidated everyone's workup to just a couple hours because we know that everybody is really busy and we try to do all of your workup into one day. But when figuring out the why, it always starts with talking to the couple. Understanding, does the female partner have regular cycles? Does she get a period every month? Is it 28 days? Is it 30 days? Is it 35 days? Is there staining or bleeding in between cycles? Does she have an issue even just getting clean and just making it through mikveh? Sometimes when we see that people have that going on, it could be a sign of diminished ovarian reserve or low egg count. It can also be a sign of other issues. When we see the patient, outside of taking the history, it's really important to do an ultrasound. And I'm a firm believer in doing a comprehensive ultrasound. And what I mean by that is doing a 3D scan so that we can take a look at the uterus to really understand, is there a reason that she's having short cycles or irregular cycles? Taking a look at the architecture of the uterus, understanding what might be preventing her from getting pregnant. And of course, then taking a look at the ovaries, figuring out the dimensions of the ovaries. Such a simple measurement to do, but understanding if they have a high volume or low volume. In fact, sometimes the volume or the size of the ovary can be a really important prognostic factor in understanding someone's fertility. Because even if you can't see all the antral follicles, all the little eggs, the potential eggs that are there, if someone has large ovarian volume, it can help you understand if there are cysts that are in the ovary or if it's a large volume because there's a lot of follicles. And then, of course, blood work. When we look at someone's blood work, I always tell patients that they're more than just a number. Of course, many people say they have diminished ovarian reserve, and so they quote to you their AMH, or they quote to you their antral follicle count. What I want to know as a provider is what is their AMH, or the measure of their ovarian reserve, but also how well is their brain talking to their ovary, and then how well are their ovaries talking to their brain. And the way that we do that is understanding someone's estrogen and follicle stimulating hormone and luteinizing hormone and progesterone. And of course, because I like to be as thorough as possible, and especially when we're doing these one-day workups, we always do a general wellness assessment. So that can be a complete blood count and basic metabolic panel, and assessing other hormones like prolactin and thyroid hormones. Lastly, genetic screening. So in the community, it's very important that patients understand the tests that they're having. And so this is always a conversation. But patients should be offered screening. Of course, if they make an educated decision not to do screening, we completely respect and abide by that. But understanding if maybe there's a genetic reason, for example, something like a fragile X carrier. And that's why someone might have irregular cycles and a low egg count. But we can typically do these 4 main things in a one-day workup. So even during COVID, during the height of the pandemic in Midtown Manhattan, we were able to have patients in our office for the minimal amount of time possible, and then to give them an answer of what's going wrong in short time after that. Now, it's always important to go back to the ASRM. The American Society for Reproductive Medicine, or ASRM, has come out with great literature over the years that helps guide the clinical practice, both for how I practice medicine, but for also how fertility doctors practice across the country. In fact, the committee opinions are incredibly valuable because they help guide treatment by helping come forward with a consensus or a statement that sums up how we all feel as providers. It's important to recognize that in the ASRM committee opinion from 2015, which has still not been revised over the last 5 years, which means it's the most recent one, there is no uniform accepted definition of decreased ovarian reserve. There's no magic AMH number. There's no magic FSH number. There's no magic antral follicle count. It's a result of you and your doctor talking together about your values and your numbers and what to do. But there's no accepted definition. In fact, in this very important committee opinion, it says that it can refer to oocyte quality or egg quantity, or even just someone's reproductive potential. In fact, it goes on to say, and this is one of my favorite points of this committee opinion, that it says that the performance of the tests is limited because it's really small sample size, or very small groups have been studied. Not everyone's the same, so a lot of the data comes from different people across the board, and there's really no validated outcomes. So remember, you're more than a number. It might guide us for our treatment plan, but remember, diminished ovarian reserve is the result of a doctor's complete assessment of you, not just a single blood test. Now, what I always tell patients is that their success is my success, and my success is their success. In short, we're partnered together to help them grow their families, either to start one or make it bigger. Now, the way to do that in the safest way possible is to know the evidence that's out there. And in fact, in February, the American Society for Reproductive Medicine came out with a really good committee opinion about treating unexplained infertility. And if you parse through those sections, it starts to come forward with a couple things. So in the unexplained group, which could be, for example, someone with low to normal fertility or even diminished, it says not to use Clomid with timed intercourse. It says not to use letrozole with timed intercourse. And it says not to use injectable gonadotropins or shots with timed intercourse. And the reason is that it says none of these really move the needle. With that said, if someone's problem is irregular cycles because they have a low egg count and their brain is yelling at their ovary to make an egg, and so they're making the egg too quickly, or it's taking them too long to make an egg, we can then use these medications like Clomid or letrozole or shots or the injectable hormones to help offer cyclicity or a regular cycle to the patient. And if we can get them into a regular cycle, sometimes we can avoid the need for IVF. So if you look at the evidence, it actually says that letrozole with an IUI can be considered for patients with unexplained, same with Clomid. and even doing low-dose gonadotropins with IUI, which sometimes patients, when you explain to them that we need a little bit more help than the oral medications, but we don't need to go all the way to the risks of twins and triplets and quadruplets of full gonadotropins, low dose actually works. I always tell them that the evidence shows that it may not make a difference, but as long as the patients know that I'm partnering with them and they're partnering with me and they understand the risks, we can try. And of course, then the committee opinion ends with saying that after 3 or 4 months of it not working with an IUI, you could consider or move on to IVF. As many of the patients and rabbis at PUAH know, is IVF for us is always the last resort because we don't want to have to do something that's maximally invasive if we can do something that's maximally effective without the need for doing IVF. So my advice, start with Clomid. It's cheap, it's available, it's very effective in certain patients. Obviously, it's much less expensive than IVF, but understand there's some risks and some side effects. It can cause mood swings and hot flashes, although on a day like today in New York, I don't know how you'd feel a hot flash because it's very warm. Then maybe layer on an IUI, which is where we have the couple collect a specimen and then the semen sample, which I know that there was an excellent talk about the halacha of collecting samples as well. But we have the sample then processed, and then we place the best sperm fraction back inside the uterus to help optimize the chances of getting pregnant. Now, I always like to bring up this paper from 2017. In this paper, they show that for those patients who do the shots and an IUI, you need to give progesterone to 11 patients to have 1 additional live birth. And so my feeling is, if you're the patient, you don't know if you're number 1 or 11. So I always give progesterone to my patients who do an IUI. And in fact, I give estrogen plus progesterone frequently. I know the evidence doesn't always support the estrogen together, but provided there's no risk factors for them, it also helps synchronize the patient's cycle to help support for future cycles in case we need to change the plan. In fact, giving estrogen during an IUI cycle could then effectively be estrogen priming if the couple has to do IVF, for example, down the road. Just so everyone understands what happens when you're taking shots, when you go through shots, if you look on the left, normally in a cycle that, let's just call it 14 days, you'll make 1 egg. On the right, it shows that taking the shots will grow lots of follicles and lots of eggs. And here's an ultrasound. And the reason I bring up this ultrasound image is that on the left, as you see all the follicles developing, I'm always looking at that lining, always trying to figure out how do we get her lining to be the best place? Because that's where that embryo needs to live for the 10 months of pregnancy. Now, if someone has to go through IVF, which is taking shots every day, sometimes twice a day, it always starts with a proper evaluation. And then for those with a low ovarian reserve, we always tell them that we like to prime. And the reason we do priming is that the month before, we're going to help synchronize all those follicles so that we can give them the least amount of medicine so they have the least number of risks, but the best outcome, which is to get the best quality embryos possible. And of course, people know that to do IVF, we have to retrieve the egg surgically, and then we use a single sperm injected inside a single egg, that's called ICSI, to fertilize that egg. Now, when we conquer diminished ovarian reserve, there's lots of innovations that are happening. It's in the ovarian stimulation, so we have lots of protocols, a CCRM, for example, specifically for diminished ovarian reserve. When it comes to the egg retrieval, we always try to make sure that even if someone has 1 egg or 2 eggs, we'll take them to retrieval to give them the best chance possible. We do our fertilization through ICSI to help guarantee the best fertilization results that we can. And then, of course, we grow the embryos, and for some, we put them back fresh, and for others, we do genetic testing. If we do genetic testing, it's a small little biopsy or sampling of the embryo, where we take about 5 to 20 cells from it. And the risk of the biopsy is very small. In fact, less than 1% of the embryos biopsied have any issues with the biopsy itself. And for those with diminished ovarian reserve, we know that if we use the genetic testing, we can get the live birth rates on a per transfer basis close to 70%, give or take, regardless of the patient's age. And in fact, for those with diminished ovarian reserve that are having lots of miscarriages, remember, one of the definitions is about your fertility potential. We can also see that we can normalize the pregnancy rates to around 65 to 70% by using genetic testing of embryos. Of course, in the end, I always tell patients, let's do everything we can to not do IVF, right? So we're actually studying at CCRM right now lots of antioxidants. So those are things like the acai berry or acai and blueberries and other different berries that are associated with anti-inflammation, people taking CoQ10 or other substances. And in fact, in a great study that came out about 3 years ago, they showed that by giving antioxidants to either the time of the egg collection or sperm collection or around the embryos can improve their outcomes. So we actually have a supplement through CCRM where we can give the acai berry, which you'll see in the bottom of your screen, for 8 to 12 weeks before the cycle. And in fact, in our patients, we found that we got a higher number of eggs, a higher number of fertilized embryos, and a higher number of normal embryos at the end. With that, I want to stay on time and leave a lot of room for questions. So thank you all for your time and your attention. And I really have had fun giving this talk to you, and I hope I've been able to help you. Good luck on your journeys, and thank you to PUAH for putting together this incredible conference. Thank you.
Great talk, Dr. Levine or Brian. We did have 2 questions. I know one of them I think you sort of answered during your talk, but I just wanted to tell you both questions by the audience. And it looks like someone else. We did have 2 questions. Okay. One question was, do we give, one talk was, what is the difference between people with diminished ovarian reserve versus poor egg quality? Can you hear me?
Yeah, I can hear you. I think you're getting feedback from your computer.
Me too.
Great question. So for those who have diminished ovarian reserve, we tend to use actually the minimal stimulation protocol for those patients, but we also have a number of protocols that are maximum stimulation. Those can be things like taking Clomid plus shots. Sometimes it's taking shots in the morning and shots at night. But our whole thing is we don't want to have to give a patient a lot of medicine if it's not going to really move the needle, because we know that the more medicine we give someone, the worse quality we get.
Okay, great. And how do you think autoimmune diseases affect egg quality?
Fascinating question. I think this is really the heart of what all of us want to know, because we know that the ovaries don't exist inside someone in a vacuum. And when we see people with, for example, thyroid disease, which is probably one of the most sensitive endocrine organs in the human body, and then we see them with diminished ovarian reserve or low egg count, we start to say, wait a second, is there something else going on here? So as we do the workup includes looking at adrenal hormones, looking at ovarian antibodies, and then also looking at thyroid antibodies. Because of course, if we have someone with autoimmune disease, they could be life-threatening if they have adrenal problems. It's also important to understand the milieu, or the environment that everything is growing in. So frequently for these patients, these were the ones where we say, let's focus for 1 month on getting the best quality eggs possible. Then, as those embryos are cooking in the lab, let's focus on getting your general health where it needs to be. So for those patients, it could be, for example, having them see an endocrinologist, getting plugged in, helping to bring down the inflammation that might be going on if they have an autoimmune disease. And for some of those patients, actually, believe it or not, it's a histamine response. And so treating their histamines. But I think the jury is still out on what's going on with autoimmune and autoimmune oophoreitis, which would be inflammation of the ovary, or autoimmune infertility. So I'm excited to see what's going to happen over the next 5 years, because I know that since I finished my training 5 years ago, a lot of literature has been put out, but still no one knows exactly for sure.
Right. Great. And then 2 other people asked some questions. What are the criteria for CCRM to be a candidate for IVF with an elevated FSH and a low AMH?
So I always tell patients, because this question comes up frequently, you're more than just a number, right? So when you come in for your evaluation, we do this 1-day workup. And we do, for example, our ultrasound. Do we see that there's a lot of follicles there or very few follicles? Or when we see a patient, do we see that, their FSH is rising very early in their cycle, for example? So I always say that there is no hard and fast cutoff. I know some clinics have hard and fast cutoffs. We don't. It's all about seeing the patient as a whole and understanding what is the best treatment plan for that patient.
Okay, great. And then one last question, if you don't mind. Can you speak to the protocols that are effective for ovarian stimulation in IVF with women that have diminished ovarian reserve?
Sure. So frequently what we find that the protocols that work best for patients with diminished ovarian reserve tend to be the 1-2 punch. And so what I mean by that is we give someone, for example, a drug like Clomid, which is the oldest, safest fertility drug that we all know of, which to help sensitize their ovaries to it. And then we layer on follicle-stimulating hormone, either Gonal-F or Follistim, and Menopur. Now, the dosing may go up or down, but for those patients, in general, it tends to work well because that lets us do a dual trigger at the end to trigger the patient as hard as we can to get mature oocytes. However, what we have found in some patients, using a Lupron-based protocol can work very well as well. So we have 3 different Lupron protocols that we use. And for the real severe diminished ovarian reserves, we tend to use what we call our full-dose Lupron protocol, where we'll give someone 20 units of Lupron twice a day and use just straight FSH, so no Menopur whatsoever. And we have very good data on our results, especially in the New York office on that.
Okay, great. Well, thank you so much, Dr. Levine. This was a very educational talk for myself, and I think for all of the viewers. If anyone has any other questions, I think that we have a way to maybe ask you some other questions.
Yeah, and I'll put my email in there. I know some people who are sitting by their computers really like to email, so just email me.
Great. That's so helpful. Thank you so much.
Okay, thank you. Have a good day. Thanks, everyone.
You too. Bye.